Hello, Pima Medical Institute dental hygienist, and welcome to your last lecture, a pre-recorded lecture for an A&P. And this is Dr. Erica Wood, in case you didn't remember my name for the past 13 to 14 weeks. I'm your teacher. Hi. Let's get into our lecture. We're going to be talking about fertilization all the way to exit route of birthing a child. Okay, so I'm going to share my screen and away we go. Okay, so this is approximately chapter 28 and a few other chapters mishmashed together. So a couple of key terms that you need to know about is conceptus. Conceptus means that it's developing offspring. It's just a fancy term that you might hear. Pregnancy is the state of carrying this offspring. Gestation period is actually the time from the last menstrual period until birth, so about 280 days. And then after fertilization occurs, through week 8, it is considered an embryo, and after week 9 through birth, it is considered a fetus. So if we take a look at our diagram here, see this tiny little pinpoints, fertilization. We'll go into what that is in a moment. After 1 week, it's a ball of cells. After 3 weeks, it's a ball of cells with a little embryo inside. After 5 weeks, it starts looking less like a tadpole and more kind of bean-esque. 8 weeks, we're starting to look more like a human, and then by 12 weeks, definitely can tell that there's a human offspring. So fertilization, in order for fertilization to occur, a sperm must reach the secondary oocyte. So when an oocyte is released, it's only viable for 12 to 24 hours. And you're like, good gracious, Dr. Wood, how does anyone get pregnant if it's only viable for 12 to 24 hours? Well, guess what? It happens. And sperm is viable for up to 24 to 48 hours after ejaculation. So when fertilization occurs, intercourse must occur no more than 2 days before and at least 24 hours after ovulation. So a lot of time you'll hear people in their fertile window, and that's when sexual intercourse tends to take place to hopefully guarantee a conceptus or fertilization, as also known as. So fertilization, what is that? So basically it's the combining of the sperm's chromosomes with a secondary oocyte to form a fertilized egg called a zygote. And remember that secondary oocyte is arrested in meiosis until it's fertilized, and then it continues its meiosis afterwards. So what does sperm have to do to actually kind of join the egg? There's a lot of different things that a sperm. It's not just like, ta-da, sperm is here to save the day. There's a reason why there's about maybe 80 bajillion sperm being ejaculated at once, because only one can actually get into the egg, and most of them die on the trip. So it's a 5-inch trip to join with the egg, so it's not much, but there's a lot of things that get in the way or kind of not super hospitable. So we have to make sure, if you ever see look who's talking at the beginning scene, it's true. They have to kind of figure out all the ways around and get to where they need to go. So some of the sperm leak out of the vagina immediately after ejaculation. Some are destroyed by the acidic vaginal environment. Some don't make it through the cervix because they get stuck in the vaginal fornix. Some are dispersed into the uterine cavity, which is fine. And some are destroyed by phagocytes because the body is recognizing it as not self. And only about a few thousand out of these millions and millions of sperm actually get to the fallopian tubes or uterine tubes. And in order for sperm to actually enter the oocyte, it needs to be capacitated. What that means is that the motility of the sperm, the flagella, has to be enhanced. The cell membranes need to become fragile so it can release these enzymes that are hydrolytic, which means water splitting, to allow for that penetration to occur. Female tract helps to weaken and thin out some of the acrosome membrane, which is at the top of the sperm. So the sperm head has something called the acrosome. Acrosome releases enzymes that help with capacitation. And then sperm itself have olfactory receptors that can follow chemical trails released by the egg. It's almost like they sniff out the oocyte. Where's it at? Okay. So acrosomal reaction at the and sperm penetration. Once the sperm reaches the oocyte, a few steps have to occur. First, it has an approach. So there's an enzyme called hyaluronidase on the cell surface of the sperm that helps digest the connection between granulosa cells and kind of opens up and goes, hey, how are you? I'm here. It weaves its way through that corona radiata. Then acrosomal reaction occurs when where the enzymes are then released from the sperm and dig a hole into a zona pellucida, which we went over in the previous weeks. And then once that area is digested, then it makes a clear path for the oocyte membrane to allow the sperm to come in. So you're seeing here, all these little sperm are going around. Only one finds an entrance route, and ta-da, it's kind of like, look who's talking. Then after that, so after we have the approach and the acrosomal reaction, then we have binding, where now the path is cleared at that zona pellucida, the sperm's tail, the flagella, goes really fast and forcefully swims into the oocyte membrane to literally cause a push and bind. And how this bind happens is that the oocyte will literally make microvilli that wrap the sperm head around it and trigger the fusion of the membranes together. It's like almost like endocytosis. And then the fusion of the membranes occur, so the oocyte and sperm fuse, cytoplasmic contents of the sperm enter the oocyte, and the tail and other parts of the sperm are left behind. So there's no sperm cell membrane, there's no mitochondria. Remember, all of the mitochondria comes from the mother. And why do we not have litters? It's because polyspermy does not occur in humans. Polyspermy means multiple sperm go to one egg. So it's one sperm, one egg most of the time. Okay. There's two mechanisms that ensure monospermy. So once that oocyte membrane is penetrated, it's blocked. And then we have something called the zona reaction, which is what ends up happening in that zona pellucidum is that granules are released, and it releases these proteins that inhibit any more in penetration into the egg. So here we're looking at events of fertilization. So we're just going step by step. So after the sperm penetrates the secondary oocyte, meiosis 2 is now being completed, forming the ovum in a second polar body. So out here, you can see all these different terms here. So we have the corona radiata out here, the zona pellucida on the inside. So think of the corona radiata as the crown that's going around, and how a crown has little divots going in and out is the same way. Then the sperm and ovum nuclei swell, and they form what's called a pronuclei, because that nucleus has to come together so we can fuse and make it go from haploid to diploid. The DNA is replicated in each pronucleus, and the pronuclei basically come together. And then they intermix. They have some that crossover reactions occur. And then we have what's now called a zygote. So now it's a single cell zygote. And what happens is that the single cell has to go through its first cell cleavage to make a baby. So this is taking a look at, so in vitro fertilization, this is actually what they do. They're actually injecting an egg with a sperm, and they're allowing this fertilization to be happening. So this can be seen under the microscope. So two have become one. If you want to sing that corny Spice Girls song, now insert that song in your head. Okay, so what's our next step? We have to go from zygote to blastocyst. And blastocyst consists of two processes. First, we have cleavage, and then it becomes a blastocyst formation. And this is normally happening in the uterine tubes or fallopian tubes. So what is cleavage? Cleavage is when the zygote moves towards the uterus and has rapid mitotic divisions, which makes a bunch of cells. So first cleavage occurs about 36 hours after fertilization, and you have two daughter cells called blastomeres. Then after 17 hours, you have a cluster of about 16 cells, and that's referred to as a morula. And then around day 4 or 5, the embryo, which is now about 100 cells, is now called a blastocyst, and it's reached the uterus. It's got to embed itself in order to stay. So the blastocyst is a fluid-filled hollowed sphere, and it has two different types of cells. It has trophoblasts, which help suppress the immune system of the womb, so it doesn't attack the newly forming being, and then or newly formed human or human in process, and then it also participates in placenta formation. Then we have the trophoblast is on the outside of this little ball of cells with a hollow inside. Then we have the embryoblast, and the embryoblast becomes exactly what you would think that embryoblast name has a precursor. It'll form the embryo and about 3 or 4 of the extra embryonic layers, and also we'll get into that in a moment, the chorion. Sorry, it won't make the chorion. It'll make the extra embryonic layers, and then the trophoblast will make the chorion. We'll get that in a few moments. So we're looking at the route from fertilization on. So right here, we're around that window between 1 to 2 days before or after ovulation, ovulation has occurred, an oocyte gets released. Sperm has reached its way into this fallopian tube and caused fertilization. So fertilization is now a zygote. Zygote then becomes the 4-cell stage right here. Then we have the morula, it's also called a blastomere. Then we have the morula, which is after 3 days. So you have about 16 cells. And then after around 4 days, 5 days, we start having our early blastocysts right here. And that morula has hollowed out. So you see here that we have a blastocyst cavity, and then we have the outer layers as well. And then the blastocyst will look like right here is that around day 7, it's going to start 4 to 5 days, it should be implanted. And by day 7, it should be basically implanted. So we see out here is the embryoblast on the inside. Remember, that makes most of the extra membranous portions of the placenta, as well as the embryo or the embryonic disc. And the trophoblast makes the remainder of the placenta. And it also helps stop mom's body from having an immunoreaction. So implantation begins about 6 to 7 days after ovulation. I say around day 10 is a guarantee if it's going to happen. And what ends up happening is after implantation, these trophoblast cells adhere to a site. It could be anywhere in that uterine cavity and could sometimes occur on the fallopian tube. They send out receptors and chemical signals, and then an inflammatory-like response occurs in that endometrium, that lining of the uterus. So inflammatory response causes the blood vessels become more permeable, and inflammatory cells invade the area. So it's technically an inflammatory event. Okay, so we're looking right here of implantation. So this is around day 4. Blastocyst floats in the uterine cavity and hatches from the zona pellucida. So yes, in human development, you will see just about every type of animal, reptile, amphibian species look until we get to human. So it shows the diversity of evolution. And then around day 6, at this particular person, day 6, the blastocyst adheres to the uterine wall. So we have that trophoblast and embryoblast. Day 7, implantation really starts to start. So we have the trophoblast, which is also then further broken down into a cytotrophoblast and a syncytiotrophoblast and an embryoblast. Am I going to have you guys know about all these specific terms? No, but I want you to have them in case you need them, okay? Most of the time with board questions, they're just asking about stages and what's going on. But I like to explain this a little bit more further detail so you can have a much more appreciation for what's going on in the body. So around day 9, this implantation continues, and the embryoblast then becomes a bilateral embryonic disc. So when the endometrium is eroded, the blastocysts burrow, and then it causes this pool of leaked blood, and that leaked blood then causes the endometrial cells it causes inflammatory markers, clotting markers, etc., to come in, and the endometrial cells will try to almost heal like you would with a scab over the area where the blastocyst implanted and seals off. So then you have it ready and anchored. Okay, so around day 11, right here, with the implantation of the blastocyst, implantation should be complete. You start forming an amniotic sac and a yolk sac at the same time. So kind of like, not to gross anyone out, if you ever had an egg, yolk sac is that yellow in the middle, it's nutrient rich. And the amniotic sac is, the amniotic sac is right here, and it's helping supply some nutrients in early formation. So trigger warning for anyone who is sensitive about talking about fertility or pregnancy loss. I do want to discuss this, but I just want to warn people before it's discussed. So in cases where implantation fails to occur, uterus becomes non-receptive again, which means that if that implantation does occur, it just gets swept out with the menses. So about 2/3 of all zygotes formed fail to implant by the end of the first week and are spontaneously aborted. Aborted means that they are pushed out and with the menses. An estimated 30% of implanted embryos later miscarry because of genetic defects of embryo uterine malformation or unknown problems. Typically within the first 4 to 12 weeks, the checks and balances system of mitosis and organogenesis and everything, or just overall development, if they see that there's a genetic area that's not compatible with life, it will naturally get rid of it. And then implantation is usually completed by day 12 after ovulation, about day 26 of the menstrual cycle, which is why when a biological female is missing their cycle around day 28, we start thinking, what happened there? So the confusing part is that the symptoms of PMS are very similar to the symptoms of pregnancy. So when a pregnancy first occurs, a woman might get nauseous. Sorry, there goes my New Yorker accent, nauseous. They might get really bad headaches. They might get really fatigued. They might get diarrhea. They might get breast pain. They might get some nipple changes. And the same thing occurs in pregnancy. So it's a really good idea if there's ever a time that a female's under suspicion, just be on a stick. It's the easiest, cost-effective thing you can do. And the important thing is, remember when we were talking about that reproductive system of the biological female, that corpus luteum, that golden yellow area that after the egg is ovulated, that follicle becomes a corpus luteum and it makes progesterone. So progesterone is to help along with maintaining help with implantation and maintain a pregnancy from the start. But the corpus luteum, once that blastocyst is implanted, another hormone is made by that placenta called the human chorionic gonadotropin hormone, HCG. And HCG will help that corpus luteum keep building up its progesterone so we don't have menstruation or accidental aborted pregnancy. So this is that P stick that everyone talks about. So it's called human chorionic gonadotropin hormone. It's secreted by the trophoblast cells at first and later by the chorion. We'll get into what the chorion is in a little bit. As I said, it prompts the corpus luteum to continually secrete progesterone and estrogen. Sorry, there's a little bit of estrogen in there that should be mentioned. And then it promotes placental development via it has autocrine, which is self-regulating growth factors. So typically after a biological woman is pregnant, we look for their HCG levels on two different terms. We look for it for qualitative first, which is that P stick. Is there enough HCG in there to confirm that a person is pregnant? Then via blood test, we do what's called a quantitative HCG, and we're looking for the amount of HCG that's being secreted. So it should technically be doubling in increments. So what we'll get is a lab test that says this person is about 5 to 6 weeks. If that HCG is under the level, then it's most likely that is not going to be a sustainable pregnancy. If the HCG is over the level of what we expect, then we're probably misdated about when that person was pregnant. And at the end of 2 months, HCG levels will no longer really show up on a P stick for the most part. And that's because the placenta is able to secrete its own progesterone, its own estrogen. And low values at 4 months and continue the rest of pregnancy, but it won't really, sometimes you will have a woman who's in their third trimester, like, they're pregnant, and you won't see a positive P stick. So this is taking a look at a graph value of what's happening with those hormones. So we see here ovulation, fertilization. So we have a little bit of progesterone that's been made by the corpus luteum. Human HCG is being made by that fertilization, and it's helping that progesterone kind of keep increase from feedback, autocrine feedback to that corpus luteum. So placenta, it kind of looks like a bloody jellyfish, which is gross, but it's the best way I can explain it. But it's not really gross because you think about it, it's like literally the organ of life. Yes, the uterus is part of it, but the placenta is what's giving that child nutrients, giving that child ways to get waste out. So it is an organ of life. The formation of placenta is a temporary organ, which means it doesn't stay with the baby forever and doesn't stay with the mom forever, because that would be bad. The placenta is made of both embryonic and maternal tissues. So obviously the maternal tissues are what contributes to it, but eventually the embryo also takes a part in contributing. So the embryonic portion of the placenta includes this inner cell mass, which gives rise to mesoderm, and mesoderm makes any type of tissue that is a connective tissue. So we're thinking muscle, we're thinking cartilage, we're thinking bone, we're thinking fat, we're thinking loose connective tissue, we're thinking all those things, okay? And then together, then that comes together with the trophoblasts, and it comes together with a few other things that then form a structure called the chorion. And the chorion looks like almost like finger-like projections, and they are called chorionic villi. When we say, like I used to work in pathology, we'd get what's called a products of conception, which means a miscarried pregnancy, we can actually see what look like little, almost puffy little flowers that are like a tan pink that will fluff up in water, and those are the chorionic villi. So let's take a look what's happening here. So when we're talking about that blastocyst, we have, excuse me, we have those maternal blood vessels. Remember, they're starting to leak and pool. They're starting to have, all these cells are starting to proliferate, and then we get this bilayered embryonic disc that occurs eventually. So we have an epiblast and a hypoblast, and then we have an endometrial epithelium here. So what's happening here is that we're just starting to compartmentalize. We're starting to having cavities to establish what's going on. 12 days, we're now seeing more differentiation. You guys are not responsible for knowing about all these terms, but more differentiation here, oh my gosh. The word that I'm trying to say that won't come out of my mouth. There we go. We're having more of that occur. And then you can see these is looking a little bit more compartmentalized. Different types of cells are forming, okay? Day 16, we're getting this chorionic villi to be formed right here. And then the embryo also starts showing what's called 3 germ layers. So germ layers are endoderm, ectoderm, and mesoderm. And we'll get into what comes from that as well. You might have had a little bit of a dental anatomy, which is why I didn't really touch upon it too much. And you have a yolk sac and something called the allantois, and we'll go into that later. So here's at about 4.5 weeks of an embryo. So looks like almost like a little tadpole. You could definitely tell that this is becoming placenta. Okay. So we have something called decidua, and decidua is basically the makings of a placenta. We have the amnion, the yolk sac right here. So here's that yolk sac, here's that amnion right here, the blue. And then this is what helps keep this is what's going to help keep that embryo nourished. You already could tell that an umbilical cord with its 3 vessels have started to form as well. And you could tell that right here is that this yolk sac is connected to that, as well as the allantois eventually. And then we're looking at a 13-week fetus, so it doesn't look as much like a tadpole. So we definitely have a true placenta. We have some decidua. We have some chorionic villi. You see a true, you see that the yolk sac is starting to definitely go down in size. That yolk sac is really meant to give nutrition from the very start. And then we have amnion and the amniotic cavity, which is where that fluid is, that when you hear a woman's a pregnancy, you hear that a water broke. That is that amniotic fluid that is coming out. And placenta is fully formed and functional by the end of month 3. So what is the placenta's job? Is provide nutrition. It helps with respiration, because remember, there's no oxygen going directly into that child's lungs yet. We learned about that in a little bit of respiratory. It's excretory. So yes, a child will poop and pee in the same fluid that they are inhaling, but hopefully it's being filtered. And endocrine functions are also occurring here. The maternal and embryonic blood supplies normally do not mix at all, for the most part, but some fetal cells may enter maternal circulation, which is why when we do a quad screen, we can actually do genetic testing very early on, because that some of those fetal cells intermix. But if we had too much intermixing, then we would have self versus non-self, and the mom's body would attack the growing fetus. And then the embryonic placenta barriers, what its job is to give a membranes, what their barriers are to make sure that they, let me try again. Sorry, my phone started ringing. I had a squirrel moment. So what's the embryonic placental barriers include is that how do we separate mom from baby is that it has membranes of that chorionic villi and endothelium of the embryonic capillaries. Okay. Now, what does this placenta do? I said it's an organ of life. So placenta secretes that HCG from the beginning until enough estrogen and progesterone is increased to sustain the pregnancy. And if that does not occur, then the endometrium degenerates and the pregnancy is aborted. And throughout the pregnancy, blood levels of the estrogen and progesterone increase. Progesterone is, especially in the 2nd and 3rd trimesters, responsible for that constipation, laxity of joints a little bit there. Not so much, but we'll get into what it is a little bit. And then it helps prepare the mammary glands for lactation, because that's what the mammary glands are supposed to be for biologically. And then placenta also makes what's called a lactogen and a thyrotropin and relaxin. Relaxin is a hormone that helps relax the pelvic floor, helps to relax pelvic ligaments to allow the body to be able to birth out a child. So a lot of times, women who are pregnant, everything is relaxed. So their rib cage can be expanded more. They're more apt to getting tripped ankles or sprained ankles. So that's important to look at. As far as the embryo is concerned, so we have now at this blastocyst formation, we have to go to our next step, which is the gastrula. And the gastrula makes 3 germ layers as well as some of the extra embryonic membranes. So remember, those 3 germ layers are endoderm, ectoderm, and mesoderm. Okay. All epithelium comes from ectoderm, by the way, as well as nervous system tissue. All the gut organs, for the most part, come from endoderm, endoderm, and then everything else falls into mesoderm. Inner cell layer mass divides into those 2 different types of layers. So we have the epiblast and the hypoblast. That's called the embryonic disc. I will give you guys key terms that I want you to know about after this. So mainly I want you to remember that first slide. I'm giving a lot of details here so you can get a good idea. First slide. So we're going to start with the fertilization zygote. We go to the morula, the morula blastocyst, and then we're getting to the next part here, which is, hold on one second, which is the gastrula. Okay, so let's talk about all these extra embryonic membranes that I keep throwing out terms, but I'm not really explaining because I wanted to make sure I was going with my slides. Okay, so the amnion is, what its job is, it makes this amniotic fluid, and as I said, it's the bag of waters that will, its job is to protect the growing embryo. Give it a nice buoyancy. It's kind of like cerebrospinal fluid. If the child had no buoyancy, they would be constantly hitting things, bruising, and probably not have a good outcome from birth. It also helps maintain a good temperature inside the womb. It's nice, warm, and cozy. Allows freedom of movement, so it won't allow friction. So if anyone in the class has had a pregnancy up to the point where they feel all this movement, this amniotic fluid is there to help allow the movement and prevent certain parts of the body being fused together. A lot of times when we hear things about like fused horseshoe kidneys or fused fingers, it's probably because there was an issue with the amniotic fluid or the amnion. And then as far as the amniotic fluid comes mainly from the maternal blood, but then later on the fetal urine actually contributes to a part of its volume. We have the yolk sac, and the yolk sac is this little part that hangs from the ventral surface of the embryo. It actually forms part of the digestive tube, and it helps give the nutrients in the beginning of formation. We have the allantois, which is a smaller outpocking that comes out the caudal end, which caudal means coming almost like from the foot or tushy end of the yolk sac. And this will become mainly the urinary bladder. And we actually have a remnant in the bladder that we could see in adults. And also provides a structural base for the umbilical cord. So without an allantois, there is no umbilical cord, which means no baby. And then the chorion, its job is to enclose the embryonic body and all other membranes and helps the placenta form. Okay, so we're gonna here, I'm not gonna go into this detail anymore. I think it's not necessary. But now we're at gastrula. Okay, so hold on. Yeah, sorry, make sure I didn't repeat my slides here. So gastrulation occurs about week 3-ish, and it's divided into 3 layers, and these are primary germ layers. And once that ends up happening is you have gastrulation. It almost looks like a giant fillet flower, and then a long streak goes through the middle of it. Almost looks like a leaf. And that's called the primitive streak. And that primitive streak is meant to establish the longitudinal axis of the embryo, as well as a site for neural tubes and everything else to come in about. So what ends up happening is that that permanent streak is formed, and then these cells begin to migrate into this little dorsal groove that's formed, and then it starts being able to differentiate itself. So the first cells that are sent in there are forming the endoderm. Then the endoderm, as the endoderm is forming, these cells are then pushed out laterally, and that forms the mesoderm. Mesoderm will make a part called the notochord. And that notochord is basically the first axial support of the embryo. And then from whatever's remaining on the dorsal surface becomes ectoderm. And as I said, so ectoderm is the nervous system and skin epidermis. I totally misquoted myself on endoderm, ectoderm, so I'm going to take back what I said a few moments ago. Ectoderm, it's become nervous system and skin epidermis. Sorry, even I, after lecturing this 50 million times, forget things. Endoderm becomes epithelial linings of digestive, respiratory, urogenital, and associated glands. Everything else becomes mesenchyme. So I always think of it as what's in our guts is the endoderm. Mesenchyme becomes mesoderm, which is just about everything else, our muscles, our bones, etc. And then ectoderm is nervous system and skin. So we kind of look at this. So I said in a nutshell, I'm going to give you something exactly what I want you to really know about is that we have egg, zygote, cell stage, 4 cell stage, marula, blastocyst. Okay. So now we're at the base of what forms a human. So we have our different cell layers and our primitive layers primitive layers in place. We have our ectoderm, endoderm, and mesoderm, and they're going to further differentiate. Okay. So after gastrulation occurs, we have what's called organogenesis. So genesis means to be made. So organogenesis makes the body organs and the systems. So this happens about week 8, and the embryo is about 1 inch long from crown to rump, and that's how we measure embryos, from crown to rump, meaning from this area of the head to the butt. And then the embryo always begins as a flat plate, but as it grows, it achieves what looks like a cylinder, and then it has these what looks like a 3 stack sheets that will eventually fold to make a tube at each end. So that tube at each end can take a wild guess. It's your mouth and your anus. Okay. So how do we get mouth and anus to form? So this is from a specialization of the endoderm. From that primitive streak in the endoderm, everything's coming along. We have what's called a primitive gut. So the endoderm literally folds in upon itself, and it makes the epithelial lining of the GI tract. And organs of the GI tract then become more apparent, and oral openings start to open. Okay. We have mucosal lines, the respiratory tract, and forms the pharyngeal endoderm, or the foregut, which is being formed. And we're not going into too much depth what all those two things are. And then glands arise further along the tract. So this is what we're looking at here. This is a 5 weeks. So it kind of looks like a bean with a tube in a nutshell. You actually do have parathyroid glands and thymus here. You still have your yolk sac, as little as it is. We have an umbilical cord. We have the allantois. At 5 weeks, there is a liver, a stomach, a trachea, an esophagus, small intestines. It is the groundwork. It is not fully developed, but it is the groundwork, and it is there. So ectoderm, it has to go through some specialization as well, and it's called neurulation. And this is the first major event of organogenesis, because we need a connection. We need our nervous system to be able to send signals all around. So neurulation gives rise to brain and spinal cord, and that notochord that I mentioned earlier, there are signals that come from it that tell the notochord that we need to start making some CNS, or central nervous system. And that ectoderm that has been formed over that notochord thickens to form what's called a neural plate. And that so if you think about it, everything starts as a line or a plate, and then it gets grooves and it folds in upon itself, and then it starts hollowing and making organs, in a nutshell. So a neural plate folds inward on itself, neural groove is formed with neural folds. By day 22, these neural folds become what's called a neural tube. And these neural tubes basically is the anterior aspect, is the primitive brain that has already been formed, and then the rest of it forms the spinal cord. Then from this neural tube, we have what's called neural crest cells, and those start to migrate, and they make different things of our nervous system. You're starting to look at things probably going, oh my gosh, now I understand why certain things are linked. I hope you're finding that. So cranial, spinal, and sympathetic ganglia and nerves are made from these neural crest cells. And guess what? Adrenal medulla, remember, that is a nervous system component. The chromaffin cells from there are being made from these neural crest cells. Skin pigment is being made from neural crest cells, as well as a little bit of connective tissues, but not by much. And by end of month 1, we have a forebrain, a midbrain, and a hindbrain. And brain waves can be recorded by the end of month 2. So now we talked about the ectoderm, and the endoderm. Let's talk about the mesoderm. So mesoderm is the reason why we have dermatome man, because of how we developed. So dermatome man, if you remember from our MSK and neuro, if someone has a problem with one of their spinal, say one of their spinal nerves or segments is pinched, and where that pain appears has to do with, so pain appears here, it corresponds to an area of the spinal cord, and that corresponds to what has been produced as embryology occurs. So this mesoderm, basically what it does is it eventually is, it first appears in the notochord, and then it becomes replaced by a vertebral column, because mesoderm, remember, makes bone, vertebral column is made of bone. And then there's 3 aggregates that first appear on the sides of the notochord as this is happening. So we have somites. Somites are 40 pairs of areas that have 3 functional parts. They have a sclerotome, which produces vertebra and ribs at each level that they're developed at. Dermatome, which is in the dermis, which is on the dorsal part of the body, and that's what gives us the dermatome sensory when we do tests. And then we have myotome, which forms the skeletal muscles of the neck, trunk, and limbs, and limbs are made from limb buds after that point. We have a part that's called the intermediate mesoderm, and that is making the gonads and the kidneys. We also have a part called the lateral plate mesoderm, and this basically makes all the cardiovascular and everything else. So let's just look at this flow chart when we get confused about what Dr. Wood just said. Okay, so it literally looks like almost like a stingray at the first when you have gastrulation. Okay, so we have this. This is at around 16 day. If we took a cross section, looks like a stingray. We have these 3 germinal layers that form from the epiblast. Epiblast makes the ectoderm, endoderm, and mesoderm. Ectoderm, epidermis, hair, skin, and nails and glands of the skin, brain and spinal cord, and neural crest, so the adrenal medulla, skin pigment cells, and most of our CNS, or sympathetic, or ANS, sympathetic ganglia. We have our endoderm, which makes the epithelial lining, glands, of digestive tracts, digestive and respiratory tracts, and all the rest. So notochord, we don't have to remember exactly what these things do for the most part. The only ones I want you to remember is that somites come from mesoderm, dermatome, sclerotome, myotome, all come from somites, which come from mesoderm, okay? If I were to give you a question on the test and you were picked mesoderm, you probably have a good chance of getting correct. So what I advise you to do is to recognize what is formed by ectoderm and endoderm, and don't worry about remembering all 80 bajillion of what else it is. So once at around week 3, so let's try it again. So yolk sac also makes some of the first blood cells that are made of the fetus. And by end of week 3, the embryo has a system of paired vessels. And these vessels basically look like an S shape. And by around 3.5 weeks, a fetal heartbeat technically is there. And if anyone's hadn't seen or had an ultrasound around 4 or 5, even 6 weeks, a fetal heartbeat is detected. Okay, so fetal circulation is a little bit different. We kind of went into a very brief overview. Actually, no, we didn't, not in this class, sorry. Last year's class we did, but fetal circulation looks different. Actually, we did go into this in cardiovascular, sorry about that. So 3 vessels of the umbilical cord here. We have an artery, 2 arteries and 1 vein. That vein basically goes through the liver. It goes through what's called the ductus venosus because it needs to bypass all this stuff for digestion, because digestion's not really taking place that much just yet in the gut. It goes through the inferior vena cava. Remember, it doesn't need to go to the lungs because the lungs aren't breathing any air yet. They are developing, but there's no lungs that are actually inhaling and exhaling. So it goes inferior cava, straight into the right atrium. And then if you remember, we have a foramen ovale right here, which closes right after birth, most people. It goes right over to the left side of the heart because we don't need to go to the lungs. And then for the parts that do get into the right atrium, they get pushed out, and a tiny bit goes to the lungs just to help with its development. But but it's not to be oxygenated. It is going through the left ventricle and out to the rest of the body. And if we notice here that the umbilical vein and umbilical arteries, we'll get into that in a moment and how they're so different. Okay. So 2 umbilical arteries, 1 umbilical vein. The things that are important to remember about fetal circulation is there's a ductus venosus, which bypasses liver. We don't really need to use it that much. We don't really need to use the gut as much. Foramen ovale bypasses the pulmonary circulation. Then ductus arteriosus, which I did not mention, because we don't really need the pulmonary trunk that much or pulmonary circulation. It goes right into the aorta. Okay, so at the end of the embryonic period, which is weeks 1 through 8, this is what has occurred. And you're like, holy moly, that's a lot of stuff that just occurred. We have bones that have begun to ossify, skeletal muscles that are starting to form and contract. We have the precursive kidneys and gonads forming. We have lungs, digestive organs that are actually starting to take their final shape in their body position. We have blood delivery to and from the placenta, and it's a good, constant, and efficient effort. Heart and liver bulge are already being seen at the ventral surface. And at this time, the embryo is about less than 1 inch from crown to rump and weighs about 2 grams. Fetal period from 9 to 38 is where the most of the rapid growth occurs. So sorry, I'll take that back. It's mostly in the embryo. It also has rapid growth at the very end of the fetal period. Fetus grows to about 14 inches, give or take, and then about 7 pounds, give or take. The average kiddo at birth seems to be about 18 to 19 inches long, and about now currently anywhere between 7 to 8 pounds. So as this kiddo is developing, there's some dramatic differences that you would see. So they go from looking like an alien to an actual human. And let's go here. So here's a look at week 7. So week 7, we have this almost humanoid looking thing. Here's that placenta. It's already right there. See this chorionic villi, how it's a fluffy pink, almost looking like a flower right there? And this is the placenta. Okay, someone actually took a scope and took a look at this in someone's uterus, I guess. And the fetus is at 3 months. So you can see the eyes are still fused. Nothing's really going on there. But you can see that you got hands, you got feet. They're crisscrossed. You got some fingers forming. And then this is about month 5. We already got 19 cm long. And it's already, you can see that tushy, and guess what? You could see some genitalia there. So typically around 14 to 15 weeks, you could start getting some differentiation of biological male from biological female. Most of the time, we wait till 20 weeks for that for that sex identification, because that's when it's definitely apparent. Okay, so here's a little bit of what happens at each period, just to have it from your textbook. So the parts that we did not go into right here is, so month 3, we still have the head as being the most largest part of the body, but as it's growing, it's getting, the body itself is getting more elongated. The lungs begin to develop and the fetus will inhale and exhale amniotic fluid. Remember, it's not so much the oxygen at this point. Liver is very large in a fetus because it has so much work to do. It's doing a lot of hematopoiesis. 13 to 16 weeks, we're getting a cerebellum that starts to become more prominent. We get some sensory organs. Even though the eyes are fused, we can have some sucking motions of the lips and some blinking of the eyes. We're growing, basically the rest of the body is beginning to keep up with the head, if not overtake it. Still, kids have huge heads. Glands are developing, and then around 17 to 20 weeks, remember, we can tell that sex of the baby. Limbs have reached near final proportions of what they're going to be at the outcome, and it's called the quickening around 16 weeks, where a mom who's pregnant can feel movement of the fetus. Personally, I felt it at 11 weeks. Everyone thought I was crazy, but it felt like a goldfish flopped in my belly. And I freaked out because I was in the middle of a class and I was like, oh my gosh, I think my baby just moved. And then I sat down, everyone stared at me like I was a weirdo. That's how it works. Okay. Then at 21 to 30 weeks, it's about month 6 or 7. This is where substantial increase in weight, growth occur. Lots of that fat has to be put on the baby. Lots of the development is starting to occur. That brain is really starting to mature. And then 30 to, the bone marrow is also starting to become, instead of that fetal liver being so big, the bone marrow is really taking over to make some more of these blood cells. And then 30 to 38 weeks. So term baby is at 37 weeks to 40 weeks. More and more fat is starting to get there. The skin, you can see here, the skin is quite translucent, but at this time, the skin starts to thicken. And as I said, it's about, so crown to rump to crown to foot length is a little bit different. So crown to rump is 14 inches. Crown to foot is going to be about 19 inches and about 7 pounds. So what happens to the mom's body as all this is happening on the inside? So we have what's called Chadwick's sign that might occur. So the vagina might get a purplish hue. The breasts start to enlarge and our area will darken, because when kiddos are first born, they can't see very well. They can only see kind of a very hazy dark versus light. So the areas darken to kind of say to the baby, bullseye, bullseye, right here. And then sometimes we have some chloasma, which is the mask of pregnancy. So pigmentation on the face will occur, almost like a butterfly mask that's tan. Other things that are not mentioned here is that sometimes there will be a dark brown line that will occur from either pubic bone all the way up to the rib cage, or even from the belly button to rib cage. So what does pregnancy do to the mother as well? So the uterus is expanding and occupies most of the abdominal cavity. This means the ribs and the thorax are starting to flare out and widen. You get lordosis, which is exaggerated curvature. So if you think of poking your butt out, and pushing your chest out, that is lordosis. that relaxin, remember we talked about that, relaxin is coming in, is literally what it says, relaxing the pelvic ligaments and pubic symphysis to help ease the birth passage. Only thing is it doesn't just work on those, it works on a bunch of different ligaments. So, and then weight gain is usually seen about 28 pounds is the average amount, but talk to your OBGYN or midwife about weight gain. So good nutrition is vital. Really just need about additional 300 to 500 calories a day to maintain a really good pregnancy. Multivitamins with folic acid help reduce the risk of fetal problems. So folate deficiency or low folate or folic acid is linked to neurological problems, and that can cause spina bifida and encephalopathy, which is spina bifida is the failure of the closure of these spinal cord column, and encephaly means no brain, and spontaneous preterm birth can occur. They also have links about possibly I hate to say this, it's somewhat evidence-based, and I've seen a lot of things that lack of folate or too much folate too has been linked with increased autism, but I can't really quote that at this point. And then, so before conceptus, I mean, this is the I won't even say this. This is a horrible body image. This is the female body, bleh, whatever they say it is. Okay. So wherever you feel comfortable in your body image is what's good for you as far as being anyone. So around 4 months is when this fundus of the uterus, that top part of the uterus, actually starts to kind of come above the umbilicus. So at 4 months, maybe a woman starts showing, as I put that in quotes. 7 months is when the fundus is well above the umbilicus. So around week 16, midwives or OBGYNs will start measuring the fundus the fundus of the uterus down to the pubic symphysis, because that gives us an estimate of what week someone is at, guesstimating. Unless you're really short like me and you're measuring at 48 weeks, at 41 weeks, then that's that. And then at 9 months, the fundus basically reaches the xiphoid process. This is the point where a female becomes really uncomfortable. And you can see here the breast changes. So in the beginning, that darkening the areola and some of the lactiferous ducts are getting a little bit more stimulated. The areolas actually start to widen as well. The nipple becomes really dark as well. And then here at the late stage, same thing. Look at all that lactiferous duct formation here. It is like, hello, that's food. But whatever way you get food and milk into a baby is your choice. But then at here, this is the point where a woman's just like, I'm done, birth it, get it out. So a couple of other things that are occurring as far as metabolic comes around. So the placenta makes a couple of hormones. We already talked about HCG. It also makes something called HCS and HPL. And what this does, it helps mature the breasts and fetal growth, and helps glucose sparing in the mother. So what ends up happening is that glucose actually gets kind of reserved for the fetus. But because of all these different types of hormones, the placenta is basically is what's called an insulin. Sorry, I'm trying to find the proper term. But basically, this is what puts you at risk for gestational diabetes, because the insulin resistance tends to occur because these hormones are there. And then parathyroid hormone and vitamin D levels are really important to stay high throughout the pregnancy to ensure adequate calcium or for fetal bone mineralization, which is why prenatals are so important. So as I said, some of the other changes, so morning sickness, it's possibly due to the increase of all the hormones. Heartburn and constipation are very common. Heartburn is actually from the physiological pushing the anatomical pushing of an enlarging womb onto your gut and pushing things up. And constipation is normally from that progesterone increase. Urinary system, because at around 5 weeks, we're making double the amount of, women are actually double the amount of blood that they need to sustain a pregnancy, which is why it's so important to screen for anemia in pregnant women. That also comes with an increased urine production because the maternal metabolism, fetal wastes are being handled by the mom. So constantly have to pee, or because that uterus is pushing on the bladder, it might lead to a little stress incontinence, which means chew, I sneeze, I bend down. A chew, sneeze, leak some urine, or I bend down, leak some urine. And then respiratory, so a lot of times estrogens will cause nasal edema and sore swelling congestion. So some people will say that this is why that change of smell can occur. Some people either can't smell, or some people are like, oh, I smell this and this is disgusting, because it causes all those different edema and congestion to occur and pushing on certain olfactory bulbs. And then the tidal volume, so the amount of volume that goes into the lungs increase, and this can cause difficulty breathing as the pregnancy gets later on. And as I said, cardiovascular blood volume increases about 25 to 40% to safeguard against blood loss during childbirth. That also means that, guess what? We increase, remember, stroke volume times heart rate is cardiac output, and blood volume has to do with stroke volume. So cardiac output definitely increases. Venous return for the lower limbs can be impaired because there's so much cardiac output, which is why some women do develop swelling of their legs and varicose veins in pregnancy. And then there are undifferentiated fetal stem cells that can enter the maternal circulation, and we don't know what they do, but some say that this plays a role in autoimmune diseases, or can be beneficial once this happens. And then the most important thing about pregnancy is teratogens. So teratogens is anything that can cause congenital abnormalities or changes in DNA in a growing fetus. So alcohol is considered a teratogen. It can cause something called fetal alcohol syndrome. So if a woman is drinking while pregnant, now give or take, most women don't know they're pregnant especially if they're younger and they're going out and having a few drinks at night. I'm talking about continuous use throughout the pregnancy. So typically with fetal alcohol syndrome, they'll have a small head, they'll be intellectually disabled, and abnormal growth. Smoking, also hashtag don't smoke. Nicotine hinders oxygen delivery, which can definitely inhibit how normal growth and development. And there's certain drugs, and as well as diseases that can cross the placental barrier. So that's why a lot of drugs and herbs are off limits in pregnancy. And then it's called torch. They are infections that can cross the placental barrier. They're known as toxoplasmosis, others, which are a bunch of other things like CMV, rubella. Let's see if I can remember them all. CMV was one of them, and I'm forgetting it. We'll get back there in a second. Okay, I promise I'll bring it back to you. It's been a while since I had to memorize all those. Okay, preeclampsia. So preeclampsia is something that you might hear about or see on your clinical charts, especially if the woman is pregnant and coming in for their tooth. Really important. That's why we monitor people's pregnancy blood pressure very closely in pregnancy. So preeclampsia is basically what happens when there's too much hypertension, so too much high blood pressure, and that causes protein to leak out as swelling into the legs. And this can also lead to eclampsia, which can cause seizures for mom, and that is dangerous. And the only cure for preeclampsia or eclampsia is to have the baby early. So pregnancy-induced hypertension that leads to preeclampsia is normally the number one reason why someone gets induced and has an earlier preterm baby. So there's a couple of other terms that we need to know about. So parturition is the culmination of baby, which means basically giving birth to the baby. And labor is a series of events that expel the infant from the uterus. So how does this happen? Give or take, this is how it happens. So we have a hormone that gets released called CRH from the fetus. That causes a fetal cortisol levels to rise. So the same cortisol we have, the fetal cortisol rises. This then causes placental estrogens to increase and progesterones to decrease. This will then cause something called prostaglandins, which, remember, prostaglandins are inflammatory cytokines that come about, as well as oxytocin at the same time. So oxytocin is then being stimulated and has receptors on the uterus. These work together to stimulate contractions of the uterus. And remember, it's a positive feedback in oxytocin. So once a little bit of oxytocin is released, then more oxytocin is released from that posterior pituitary. And this causes more uterine contractions. The uterine contractions pushes the baby down, which encourages the uterus, the cervix to stretch and dilate. So there are 3 stages of labor. The first stage is dilation. Dilation means that from 1 cm to about 10 cm. It's the longest stage of labor. It can take about 6 to 12 hours or more. You have a little bit of weak contractions that are about 15 to 30 minutes apart, and then last about 10 to 30 seconds long. And as they become more vigorous and rapid, it helps the cervix become a face, which means thin out and dilate to 10 cm. 10 cm is about the size of a bowling ball. Yeah, that's how big your cervix gets, or not yours, but a person's cervix gets when they are ready to be birthed. Then the water will tend to break at this point. Sometimes this happens in opposite order. So if the amniotic fluid breaks before any of this happens, this is the reason why people get induced and have C-sections, because once that amnion ruptures, you have exposure to the outside world, and also you're losing that fluid, which prevents friction and movement and allows movement. So then we have something called engagement that occurs, where the head enters the pelvis. The baby's head will rotate, allowing to get into that pelvic outlet or into the bowl of the pelvis. So here's early dilation. Baby's head is engaged, which means that it's down in the pelvis. It's at its widest dimension. It's pushing on there, and see that the cervix right here is a little bit effaced. It's a little bit thinned and a little bit dilated. Late dilation, look at that. Fully thinned out cervix and to about 10 cm dilated right there. Then we have the expulsion stage, which sounds gross or nasty, but it's not. So this is from dilation to deliver the infant. This is what we call the 411 or 311. So we always say in midwifery or OB/GYN, when is a good time to start going to the hospital is when you are having 4 minutes per contraction that have lasted for 1 minute that occur for more than an hour. That definitely means that birth is imminent. You also have an urge to push. A person has an urge to push when this happens, unless there is an epidural done, which will have the person not have the sensation. And then we have what people have heard as crowning, which the head is actually distending into vulva. Sometimes there's not enough room outside the vagina into the vulva, so we have to do something called an episiotomy, where they cut the vaginal orifice in order to reduce tearing. So women can get tears when they're birthing. It could tear the vagina, it could tear the perineum, it could tear the urethra, it could tear the rectum. Okay, so upon expulsion, the head's always down first. If it's not, then that person's having a C-section. Baby's neck extends, it kind of goes like this as it's exits out the perineum. Once the head is delivered, everything else comes out much easily. The trickiest part is getting that head out. Vertex position means head first. That's how we want a baby to be born. The skull, when the skull pushes on the cervix, it helps it dilate. And then if this doesn't fully come out, we sometimes see babies with like like hickeys on their heads, because they use a little suctioning to help allow it to come out. And then we have what's called breech position, which is never a good thing to have. It's buttock first, so sometimes they will try to manually from the outside, if they know this has happened before labor has started. They'll try to literally go in and move the baby and have the baby in the right position, hopefully. But if this does not happen, then normally a C-section occurs. So ta-da, this is the head coming out. This is expulsion. Head has entered and everything is great. So what's going to happen to this placenta when we're all done? So the placenta has to come out too, and it's called the afterbirth. It typically happens around 30 minutes after birth. So normally, even though the baby has been born, and women always like, like also they have this amounts of pain, they totally forget about it. That's that oxytocin flowing. That's that love. That's all those hormones going. You're just like, screw it. I don't care. Look what just came out. Amazing. But those contractions are still going on. And what that does, it helps the placenta detach and helps that uterine blood vessels to kind of compress and shear itself off. Most of the time this comes out one felt swoop, but sometimes it can be stuck, and placentas can get stuck to the uterus, which can cause issues. So we always have to make sure it's present. So after a woman gives birth, we always monitor how much they're bleeding, because if they start bleeding heavily, then that probably means there's placenta stuck. So umbilical cord should always come out first, because it's attached to the baby. And if it's not, then we have it should always be attached to the baby, but the cord. So the baby should come out first and then the umbilical cord. If the umbilical cord comes out before the baby, that's dangerous. If the umbilical cord's wrapped around, a lot of things can go wrong, and I don't mean to scare anyone, but you guys can Google what can go wrong. I'm not going to give anyone anxiety here. Too late. So after the baby is delivered, the placenta detaches itself and is removed. It does typically go, doesn't always go to a pathology lab unless there was problems with the pregnancy. Sometimes I've dissected over 3,000 placentas in my lifetime. Normally that's from gestational diabetes, oligohydramnios, which means too little amniotic fluid, or polyhydramnios, which means too much. Or if they go over 42 weeks, we have to make sure that the placenta is healthy, and also check for umbilical cord issues. So we have certain things that occur in pregnancy that you should know about, which is dystocia, which some women have a very narrow pelvic bowl, and this can make labor very prolonged and difficult. That was my issue. Actually, full disclosure, I had a C-section. There just wasn't enough room for baby to go through, and what actually happened is that What actually happens is that when this did not happen to me, but the shoulder can get stuck on the way out if there's not enough room, and this can cause big issues. Other issues with dystocia is that if they're trying and trying and trying to get this baby out, but there's not enough room to get out, and it's 48 hours, yes, that's how long I was in labor for, 48 hours and they're just done, maternal fatigue can occur or fetal brain damage can occur. I definitely had the maternal fatigue. And what do? They C-section, just get it out, safer to get it out. And then lactation comes about as soon as that baby is born. So milk is made by mammary glands. Remember, prolactin makes the milk. Oxytocin is still being worked to let the milk down. Hypothalamus has been responsible here. So typically we have what's called colostrum that's being made, which is maybe just like a little drop or two. And as that baby starts feeding, it provides a feedback loop for the body to make more. So typically it takes about 2 to 3 days for true milk to come in. And that is okay. That is typical. That's why it's so important to feed often and keep watching that child as much as possible. So typically colostrum is the first thing that comes out. It's a yellowish fluid that has less lactose, but it has a ton of minerals and vitamin A. And then the true milk has all the fat. But the good thing about colostrum is that it has all these antibodies in it, the IgA, they're secretory antibodies. They give tons of immunity for the baby. So yes, breastfed is best for Atward, but I say fed is best. Don't feel any shame in your game if you can't do it, okay? Or don't want to do it. So I already told prolactin, everything else. There's also this suckling that occurs from the baby, also triggers more prolactin to be made. And as I said, oxytocin is that letdown. So that also gets triggered by suckling as well. Suckling sends messages and reflexes down to the brain. Oxytocin gets released and causes ejection of the milk. So here's all that in a nutshell in a flow chart. Now, what are some of the, so remember, fed is best, but breastfeeding is a preferred. Breast milk is high in fats and irons that are better absorbed and has amino acids. It has all those immunoglobulins, or IgAs, that are really important. We have a ton of immune support in there, and there's glycoproteins in there as well that that help help the gut stay protected. Also helps natural flora to be colonized. And then it also has a natural laxative effect. So babies typically have this poop that's called meconium. It's like a tarry green black paste that should be gone in the first 3 to 4 days. And if a baby's strictly breastfed, eventually that poop in a baby once they're born looks like a mustard seedy yellow consistency with no smell. So women are suggested to nurse for at least 6 months. But if they are nursing, I mean, remember, this is taking nutrition out of them, they're losing bone calcium and they're also losing their own nutrients. So women tend to be really hungry and continue taking their prenatals to help this from not issuing. And the fun thing is they're like, oh, I've been breastfeeding, there's no way I can get pregnant. Nope. So yes, breastfeeding technically inhibits ovulation, but that can occur despite all this happening. So I think the term is Irish twins, which I don't like using because it's not a good way to use the term, but that is basically what happens, is that they think someone thought they couldn't get pregnant, and they did because they were still able to ovulate. Hormones come into place after with breastfeeding. So some women don't get their period until after they stop breastfeeding. Some women do. So the best way to prevent another pregnancy, if you're not wanting a really close together age, is through condoms. And then assistive reproductive technology, it says 1 of 4. There are not 4 slides on there. I just figured it was a good time to see this because you'll see a lot of this lately on charts. Unfortunately, more and more people are having difficulty with fertilities. In my opinion, this is where naturopathic medicine shines. But what we do is that we can either do where we could do semen analysis that makes up we do semen analysis and fertility studies. We can do artificial insemination, which means taking the sperm and injecting it into the uterus. We can fuse the egg and the sperm together. We can trigger ovulation. And if there's any blockages with blockages that are occurring, we can look at surgeries to help open those uterine tubes, because if those uterine tubes are scarred or blocked by fibrous tissue, they're not going to be able to have fertilization occur to allow implantation to occur. As I said, this is where naturopathic medicine shine, but I also want to give a shout out to acupuncture as well. So I hope you guys enjoyed these past 13 weeks, soon to be 14 weeks. and enjoying your Labor Day. Have a good one.